Hi everyone, my name is Florence Rigal. I'm the president of MDM, and I'd like to welcome for this 9th scientific day regarding solidarity and humanitarian health. So today, we are organizing this day in partnership with the MDM Foundation that we'd like to thank. And so this is the second time that we are within the Le Monde Auditorium for other editions or previous editions. We used to be in other facilities. But so thank you so much for welcoming us today. MDM has been founded 45 years ago. This is an international solidarity and humanitarian association, and we have teams fighting in about 30 different countries, including France, so that people can have universal access to health. I'd like to remind you that our association has a specific spot when it comes to the humanitarian and solidarity sector, because we are based in France and at the international level for over 30 years now. We do activities for the most vulnerable people, and our mission is also to be a witness and to denounce everything that is made impossible for people to have access to health. And we fight for social changes. We want to have long-term changes, and we want for everyone to have access to health. We differentiate ourselves by going in the field and by going to countries where others do not go. We also fight against injustice. For us, all of these topics are extremely political, and this is why we always put them in the public space. And this is exactly what we're doing today with the Scientific Day. This annual meeting is a discussion moment that is extremely important. When we talk about precarity, we talk about health, and we talk about humanitarian aid. This event is helping us out to shed light on the operational results and on the study results as well that we conduct all year long. So this is a perfect opportunity to debate and to think with guests, with players from the humanitarian aid sector, with people that are concerned by this humanitarian aid, and also people from different institutions. So this scientific day is an open opportunity. I mean, this is an opportunity that everybody has access to, whether you're a public health specialist, whether you're a student, whether you're a volunteer, or whether you're just interested in the topic. It's important to be informed on what's happening in the humanitarian sector. It's important to discuss with the different players as well. At MDM, research is not just a simple word. Research is precious because this is how we can acquire new knowledge and how we can analyze what's going on so that we can have a stronger impact in our advocacy, but also in our activities for our beneficiaries. So we do research for several objectives. We want to improve the quality of intervention in our practices. We want to better support. We want to prevent. We want to care. We want to take people's needs into consideration. We also want to gather data and get more information so that we can elaborate better advocacy as well. We want to be more legitimate as well when it comes to speaking in a public space. And hopefully so that we can get data and information that would help out legislators to make the right decisions. For MDM, research is an important lever that contributes to implementing actions for people to have access to care. It also contributes to better understanding public health matters. And with the results of that research, we're able to go up to authorities and institutions and tell them about problems that are usually ignored or neglected. Finally, research is also helping us to get a scientific perspective when it comes to our interventions so that we can reflect on the way we work. We also are really interested in participative research because it helps us to take everything into consideration and to take all of the populations concerned when it comes to public health and prevention.
Aussi, la recherche ne peut se faire en silo.
We also know that it's impossible to have a siloed research. It's why it's so important to break the silos and have different actors, different players and researchers with us today, so that we can all take a step back. It's really important for us to reflect on best practices in humanitarian and solidarity in the solidarity sector, so that we can keep on moving forward, so that we can improve our work. Of course, getting this feedback, getting this discussion time, everything is supported by scientific research. Humanitarians, players, target populations are usually faced with many challenges when they're working with precarious populations. They're trying to understand the life of these communities that have a very peculiar life, to try and find solutions that are efficient and so that they can meet their needs. So how can we mobilize what we already have so that we can help people that are in a vulnerable situation? How can we identify people that need help? What are the different innovative methods that we can use, especially in the humanitarian context? Throughout the day, the different speakers will be presenting their work and their studies. And they will tell you more about the different factors that actually foster precarity. They will also make recommendations and suggestions. The idea there would be for us to reinforce our capacity when it comes to our intervention capacities. Acts will be elaborated at the end of the day so that we can get the key guidelines and key recommendations. So this year, we will be talking about the intervention for and with precarious populations, with the following question: how can we understand, act, and transform? So this red thread is going to help us out to explore the different challenges that we have in the different interventions that we conduct. So we'll have 4 different roundtables for us to have a global vision that will be moderated by MDM players. So this morning, we'll have a comparative views on social and health insurance systems and policies in the face of inequalities. We will also get another roundtable that will be about empowering people, issues, and challenges. So this is for this morning. This afternoon, we'll talk about political and institutional constructions of social stigmatization in France, historical overviews, current findings, and ways of combating them. And finally, we'll finish with innovative practices to the service the population that are far away from the health system. So to help out precarious people, we need to understand better, to collaborate. We need a better collaboration in between MDM players, institutions, and the population in question. At the end, we'll have a cocktail all together, right where we had breakfast this morning. So we have other technical aspect for today that I wanted to share. You can follow this entire scientific day in French and in English. I actually forgot to say that at the beginning, but we have people that are connected remotely. And so at the end of every single roundtable, we'll have a Q&A session. So we'll open the floor to questions, whether you're in the room or connected on Zoom. And to conclude, and before giving the floor to the moderator of the first roundtable, I'd like to thank all of the speakers that are coming here today to share their knowledge and help us out think about our work. All of your contributions are extremely precious to us in our fight against precarity and injustice. Thank you also to all of the teams, MDM team, that worked really hard in the past few months to organize today. Thank you to the technical team as well. We know this is a huge challenge as well. And let's not forget you, the audience, because there are a lot of you here in the room today. I'm hoping that we'll have fruitful debates, we'll have acquire new knowledge, that will elaborate new strategies so that we can improve our interventions. Finally, I wish you a great day, and let's start the debate. Hi, everyone, for those that are in the room, and hi to those that just joined us on Zoom as well. I'm delighted to start today with the first roundtable that will be dedicated to social and health insurance systems and policies. So in France and at the international level, you know that MDM is fighting for a universal and unconditional access to health. This is a basic principle, and this is a fundamental and paramount for people to have access to healthcare. We know that in France, most people that are within the territory, that reside on the territory, they usually have health insurance to cover their health fees. But we also know that the situation is degrading. This is also what happened in the past few months when it comes to the fees that actually increased and reimbursements that went down. And so it's pushing people away from healthcare. Within the people that reside in the territory, we also have undocumented individuals or precarious individuals that have to overcome many obstacles so that they can have access to healthcare. They have access to what we call the state medical assistant, the SMA. But as we know, it's being reformed over and over again. This is what we've seen during the migration law that passed a few months ago in France. But we'll get back to this later on. So within this context, of course, we need to acquire more scientific knowledge so that we can try and try and have more information to share with the public and with the different authorities and institutions. This is why we asked for Agnès Gillino to get here. She's the general coordinator for MDM in Nice. She knows everything about how to get access to state medical assistance, and she's been working with precarious people for a long time now. So she's also able to talk about the degradation of this entire system, to try and debunk fake truth when it comes to public policies. We can also rely on the MDM Observatory, but also on scientific data. We have Antoine Massaudon with us. He's a researcher in the health economy. And so he worked on the welfare state, the role, costs, and results of the state medical assistance, actually. When it comes to state medical assistance, we, of course, have challenges when it comes to universal health insurance, which means that this would include every single person living in the same territory. And so this is why we also suggested Valérie Ried, a research director, to come over here and to conclude this roundtable. So she's going to talk about the department-based mutual health insurance schemes in Senegal. So here again, this will be all about the showing you how scientific knowledge can help us influence public policies. But without further ado, and after this very short introduction, I'll just yield the floor to Agnès.
Excusez-moi. Bonjour, j'attends le PowerPoint. Voilà.
Hi everyone, I'm just waiting for my presentation to be displayed. I'm the first one, so I'll just test the remote for everyone. So just bear with me. So hi everyone, I am the general coordinator for MDM in Nice. And so to start my intervention, I'm going to yield the floor actually to a patient of mine that we've met, that we've supported. And what we've done is that all of our testimonies have been aggregated. So keep in mind that she doesn't speak French really well. She says, hi, my name is Justine. I'm from Mauritius and from Mauritania, and I don't have any papers. I can understand French if we speak to me very slowly and with very simple words, but I can't read it. I arrived in France 3 years ago by crossing the sea. I had to live in the street for a couple of months, and then I met a man. A man that is hosting me. I don't pay him with money, but it's just like if I was paying him. Now I'm able to work. I can do cleaning missions, and I've met a friend that suggested that I could come over to her place and live at her place. I said yes because I feel more at ease and I can give money to her. I got sick a year ago and I went to see the doctor, and he gave me medication for my high blood pressure. I can no longer pay for medication because I have to pay 400 euros for the room at my friend's place. So they told me about MDM, and so what I did is that I went to MDM and then I saw a doctor. But I was also told that I could have access to the state medical assistant and no longer pay when I go and see the doctor or go to the pharmacy. But I need to have an address. And my friend doesn't want to say that I live at her place. She's afraid because I'm an undocumented individual, so she doesn't have the right to help me. So for the address, I asked the man from before. He said yes, against 150 euros. You get it? And I also was asked to give an address to the intermunicipal care center, and they've asked me for supporting documents to prove, where I live. In the end, the social worker from MDM was able to work with the intermunicipal care center by writing a paper stating that she knows me. I had to go get the paper to the state medical assistant at Social Security, but it was hard because the security guard didn't want me to get in because I had to take an appointment with the 3646, but with my phone I can't call because I don't have enough data to call. So I went back to MDM. The woman had to wait 15 minutes when she called for me before anyone picked up the phone. And the social worker told me that I couldn't just lodge my application because you need to have a 3-month residence proof. So I had to wait for 3 months. Then she helped me to file my application, and I had to call 3646 again to get my appointment. And I've been able to lodge my application. 2 months later, they sent me a paper, and I couldn't understand anything. My friend told me that they wanted all of the pages on my passport, but I've given them already. So I had to do all of the photocopies again and send everything again, which costs money. But thankfully, MDM is now providing my medication for my high blood pressure because I don't know what I would do if they weren't there. Because I asked for my state medical assistant 4 months ago and I still don't have anything. With MDM, we call the 3646 again. We just wait and wait and wait. And when they pick up the phone, they tell me that my application has never been received. And it's impossible because I did get the paper from Social Security. So I called again and I waited again. And then another person says, okay, they found my file, but all of the passport pages are missing. When I said that I've sent them, she said that she's going to send a message to her colleagues. I waited 2 more months because I didn't get anybody's response. I had to go 3646 again, and I'm a bit ashamed because every single time I have to go to MDM for them to make the call for me. And then at 3646, they're telling me, oh, but you have rights. You just have to wait for us to manufacture your card. And we'll recontact you. Finally, I got my card, but the card was expiring 6 months later, which means that in 4 months from now, I have to start all of this process all over again. But I still had the chance to get back to see my doctor, and my doctor is not complaining about me having the state medical assistance because my friend told me that her doctor does not want to take the state medical assistant. So thank you to Justine for this testimony. From the moment that she heard about the state medical assistant, over 2 years after she actually arrived, after she set foot in France, and the moment in between she asked and the moment she got her card, almost a year passed, about 10 months and a half. In 2001, Justine only would have had to give 3 different documents: ID, statement, and she would have gotten her state medical assistant in a month or 2. And Justine's case is no exception. We get people that are in the same situation almost every single day. And so her case shows how incredibly hard it is getting now to actually get access to the state medical assistant. And so what I'm going to do is that I'm going to divide my presentation in 3 different parts regarding the evolution of the law.
L'évolution du droit, une deuxième partie sur les...
So the first part will be regarding the evolution of the law. The second part will be about the evolution of practices. And then finally, we'll talk about the real consequences on beneficiaries and potential beneficiaries, potential as they are potential beneficiaries several months until they actually get their SMA card. So in 2000, there is a huge reform when it comes to health insurance. So they do create the universal medical insurance, medical care. So this is not part of the Social Security Code, but people do have access to some health services. So there are 3 different criteria. You have to be undocumented, you have to be under a certain threshold when it comes to your income, and you have to have a stable residence within the territory. So what really changed over time is basically the way that we assess the stability of legal residence in the territory. So at the time, you just had to state on a paper saying that you swear that you do live in France, that it's not just occasional. There's another right principle here that says that this is a declaration or a declarative statement. You don't have to give a supporting document. Then there was a difference between total medical assistance and hospital care for people that had been in the territory for over 3 years. So over 3 years, you were able to get assistance for all type of care, whether at the hospital, whether in the city, and so on. For those that were there for under 3 years, they could only go to the hospital if they wanted to be reimbursed. Then in 2002, there was a first reform that was in the finances law, actually. And so what happened is that you could get full SMA, whichever duration you had been on the, no matter how long you've been on the territory. And so when it comes to the stability of residence, it works from the moment that you've spent at least 3 months in France. So we had to wait then up until 2005 so that this condition, this criteria of being present on the territory for over 3 months, and you have to wait for 3 months because you need to have proof, you need to have a supporting document. It was funded by the Vital and Urgent Care Unit, in which we consider that a person can be cared for if their life is at risk. Then in 2005, another decree is changing the way that we establish criteria regarding the supporting documents, regarding your ID, regarding the stability of your stay in France. So you need to have a passport with a visa, a dated visa, or you need to have the stamp on your passport as well. And if you don't have that, you can just also give a document that says that you've been hosted by someone or that you've been at the hospital for some time. So we also make a distinction in between active and inactive Europeans. So Europeans that are part of the EU. So I'm trying to sum this up and make it a bit brief, but it's hard. Basically, EU people that work, they're active, so they have the right to have access to social security, to have a health insurance. For the inactive ones, they don't have access to that social security. And so at the time, it meant that if you wanted to have access to the SMA, you had to pay for a 30-euro entry ticket, but then it was cancelled after 2 years. And then the last restriction package that we've witnessed was back in 2019, is that they got rid of that 30-euro entry ticket, but then you have to be undocumented, which means that if you get in the territory with a visa, with maybe a residence permit for 3 months, then you don't have access to the SMA. It means that you'll have to wait for another 3 months. That is to say, 6 months from the moment that you set foot in France, that you can actually ask to get access to the SMA. Regarding other changes that we've had in 2019, the first application that you lodge, it has to be done directly at the counter, which means that you no longer can work with people that work in an association. Everything is centralized as well, so you only have basically 3 different CPAM funds. So you no longer have a direct person to talk to, the CPAM being the local healthcare insurance fund. So this is the evolution of the legislation, but then I wanted to tell you a bit more about the change in practices as well. So, in theory, it's quite simple. I mean, it's supposed to be simple from the beginning, but it meant that you only had to make that statement regarding your residence. But if it was simple, the fact is that this system was quite unknown from beneficiaries, from the CPAM. And so depending on the CPAM that we're talking about, some were refusing to actually help people to lodge an application. So the practices were really different from one CPM to another one, to the other. And the 2005 decree should have fixed that problem, but it wasn't the case, up to the point in which in 2008, the CNAM released a letter to all of the CPAM directors regarding the harmonization and standardization of the CPAM practices, so that we would have a list of all of the documents that would be required. But we've seen that over the years. We've had a lot of abusive requests when it comes to supporting documents. And, CPAMs can be extremely innovative and creative when it comes to supporting documents that they might ask. We have some trends as well that we observe. That could be 1 proof per month, or sometimes it's having all the passport pages. Some other times that would be having the ID of the person that actually hosts the undocumented individual. So, things are changing over the years. So what we can say now is that the only proof of presence in the territory is basically related to people's address. There is no proof of lodging an application, which means that you cannot appeal to anything if needed. It's also quite complex for Europeans because, as I said, this is the CPAM who's going to assess whether that person is in a regular or irregular situation, but I'm not going to go into details because otherwise we're here up until tomorrow morning. But it means that, it leaves a lot of space for interpretation here. So it makes it even more complicated for people to get access to this. So it's a lot of red tape, and under COVID-19 context, a lot of counters were closed. And as Mathieu was saying in his introduction, now that we are digitizing everything, it makes it even more complicated for potential beneficiaries to have access to this. So, of course, people don't really know their rights, they don't really know the different structures. And so the figures that you have here on the screen, so it comes from the care centers of MDM. And so here it shows that people don't really know what the SMA is about. People don't really know what is their rights in terms of health, but we know that red tape issues are increasing a lot as well. So in the different care centers of MDM, we can observe as well we have less and less, fewer people that can be eligible to the SMA. And for people that actually have acquired rights or have the potential to get acquired rights, well, there's also a decline in this number of people. The consequences here, as I said, those people do not have access to all of the different campaigns that are organized regarding prevention for cancer or for children's teeth, for example. They don't have an health insurance card, which means that they can't get automatically reimbursed. They cannot create their account on Amélie.com as well because they just don't have access to a computer or don't really have access to the internet all the time. All of the people that were meant to help them out are no longer working, so they always have to call the 3646 platform. And as we've seen with Justin's testimony, with the phone plan that she has, she's not able to call 3646. And MDM has participated to different events in the Île-de-France region, and we know that 38% of calls that are made to the 3646 are never picked up, which means that almost 40% of people just never get an answer. And the obligation of filing your application at the counter. Well, through this survey here, we've been able to see that a third of the people take about 1 hour to get to the counter, and then they have to wait in line, which means that most people just have the choice in between taking a day off, and of course they risk to lose their job because they work on the black market, as you know, as they are undocumented, so that they can actually have access to care. So consequences here is that people usually ask to be taken care of a bit too late in the process. The figures here are quite stable, so they seek care later than they should. And we can see, though, that we have a huge increase in terms of people that no longer decide to seek care because they don't have the money, they can't afford to actually seek care. And so 65% of the people that we had at MDM simply renounced to actually get the care they needed. Then when it comes to institutional violence, they're highly exposed to it. As you've understood, Justine had to pay with her body for her to have a room at this man's apartment so that she could get an address, so that she could get the SMA. So I would say that the SMA is a very fragile system, and it's degrading because of what the authorities are doing. So it's not so costly because it's less than 0.5% of the social security budget, and it's often put back into question. And in the past few months, it has never been truer than before. We also have a lot of rumors when it comes to the SMA, saying that people come over just to get access to care, and the universal health care is actually not universal because it doesn't cover people that do not have a residence permit. But what we've been able to observe in the past few months is that we want to make sure that nobody's excluded from care. And if this right is being guaranteed, it means that it will be guaranteed for the entire society. Thank you.
Un grand merci, Agnès.
Thank you so much, Agnes, for this presentation. It sets the tone for today's conference. Thank you for giving the floor to Justine as well, because it was also the opportunity for us to give the floor to all of those who cannot share what they've lived and that cannot share the dysfunctionings in their access to care. So thank you so much also for reviewing the dysfunctionings of the MDM Observatory when it comes to the law or the practices, because it's a very good transition with our second participant, Antoine Maraudon, researcher at the Institut de recherche de documentation et d'économie de la santé. So there are a lot of surveys that are being carried out outside of MDM. So can you please tell us more on that study? Thank you so much.
Avec plaisir. Merci beaucoup, Mathias.
Matthias. So first of all, I wanted to thank you for coming. Thanks to the organizers as well for organizing that scientific day, because it seems passionate. I think it's going to be passionate. And thank you to the two people here, the two members of the panel. You're going to see that there is a strong link between qualitative and quantitative studies, and it's also a way for us to have a thorough view of the consequences of SMA and the consequences on people that seek care. So I am an economist, as Matthias said. And so a lot of people are wondering why an economist would talk about care in the first place. And our role is to understand that there are some consequences in between two variables. So that's the goal here. The goal is to better understand if, for example, one variable has a consequence on another. So we need to find the root cause, and once we have the root cause, we can have an impact on it. We can change it if collectively we consider it needs to be changed. So when you are a researcher, when you're an economist, you do a lot of statistics. You create models, and you're trying to understand what's behind the data thanks to different models. And this is what I'm going to show you today. I'm going to show you the results that were given by different models. We're not going to have a look at the equations, of course. We're going to focus on the results. But this is our job. This is our starting point as a researcher. And you're going to see that there are a lot of different interactions, a lot of links with what my colleague said, Agnes. So we have the data, and there are also a lot of things that we don't see. And we've heard from Justine, if I'm correct. And so there are a lot of things that we cannot really collect in terms of data. And so that's why qualitative and quantitative research are extremely important. So I'm now going to talk about SMA because it's been presented already and defined already. So it's been mentioned already, so we are economists. So we don't focus on costs only, but we need to think of it nevertheless. It's paramount when we talk about SMA, because it's something that is very scrutinized. So here you have the evolution of the costs of SMA for several years, and it represents around 1 billion euros today. So it depends if it's a perspective, curves, but on average, we talk about 1 billion euros. And as Agnes said, we could say, okay, it's a lot, but when we have a look at the consumption of care services, so the expenditures around health represent 200 billion euros, and you can see that 1 billion euros is not a lot. It represents only 0.45% of costs and expenditures, so it's not a lot. So we can save money on that, but we're not going to save a lot of money because it's a very small part of the full budget. So you can benefit from SMA, but sometimes you do not seek care. So this is, you can see here on the screen with the different curves. So in red, you have the people that benefit from the SMA, and in blue, you have the number of people that have access to care, that get care. So we're talking here about one registration at least during one semester. So you can see that there are fewer people getting access to care compared with the number of people that get access to SMA. And here we're talking about a decrease here of 30 euros. It's an entry ticket that no longer exists today. So we asked ourselves two questions, the following ones. So public health questions, basically. What are the factors, the drivers that lead to people not to seek care and not to benefit from SMA? So we wanted to find the relationship in between people not getting SMA and not getting access to care. And so then we need to understand what needs to be done to reduce the number of people that do not benefit from SMA. So that was the first question. And the second one is the following. Do people that benefit from SMA have a different pathway when it comes to the access to care, get access to care in a different way? Here it's to rather assess the efficiency of care services. So with the SMA system, the goal is for people to go to a private office rather than going to a center dedicated to people that are vulnerable. So if you go directly to a medical office, it means that you're not going to go to the hospital. So it means that we are going to reduce the overcrowding of the emergency rooms. We're going to reduce the costs. And if people are monitored regularly, on a regular basis, it means that care services, the care that they need, will be also happen earlier on, and so it means that their health will not deteriorate that much, and we know that it costs a lot. So these are the two questions that we focused on. And so for that, we needed also data. So we've tried to collect data. So I haven't mentioned it, but the data that has been collected, well, the collection of data was funded by the Institut de la Recherche. And the goal in return was to create a sample that would be as representative as possible of the undocumented individuals. So there are already some databases that do exist, but we have to say that those databases target specific places, specific locations. For example, if we wanted to have an overview of the general health of the French population, but if we collect data in hospitals, we're going to think, okay, French people are not healthy. But it's counterintuitive, because if we collect data from hospitals, well, we know for sure that people are not healthy. It means that we are not going to have a good representation of reality. It's going to be biased. So the goal was to collect data in medical centers, that's for sure, but not only, because we really wanted to have a population that would definitely represent the whole population of France. And behind this, the goal was to make sure that if we have a cross-representative population, thanks to, even though we make mistakes, we can think that we can make conclusions. It means that the sample would react in the same way as the population, so we can then extend the results to something more global. So we know that undocumented individuals cannot really fill in a questionnaire, cannot really share information with us. So, we look for undocumented individuals that go to centers for precarious people. So it's the first restriction. It means that we cannot target the whole population of undocumented individuals. We are going to target people that are going to centers. So it means that there are people that are not taken into account, marginalized people maybe that do not go to the centers, or to the contrary, people that are more integrated maybe, or people that have a relative that can welcome them, for example, or house them. So we are trying to have a good representation of people that go to centers for vulnerable people. So how did we do that? So we got some listings, so we worked with the City Hall of Bordeaux and City Hall of Paris. We decided to focus on those two specific cities because we have a pool of experts there, so that's why we've decided to focus on those cities for technical reasons as well. So we've worked with Paris and Bordeaux, and so they shared the lists of all of the different structures, centers, that are welcoming vulnerable people. but it doesn't necessarily mean that they welcome only undocumented people. So we had to call any of those structures, all of the structures, to ask them whether or not they would welcome undocumented individuals. And so we have set a threshold of 20 people per week. It's debatable, of course, but we really want to have structures that welcome enough documented individuals. It's not just one person that joined the center once during the year. We really want to have stable data. So we set a threshold of 20 people per week. And so in total, we had 63 centers that would fit with those criteria. So we didn't want to have care centers only. So I'm not going to enter the details of all the different centers, but we have in total 30% of medical centers, but for the rest, for the remaining 70%, we have different types of structures. We can have food aid centers, centers that give clothes, for example. We can have paperwork aid centers. So we decided to have a broader approach and not to focus only on medical centers. So what are the results? We have a lot of figures here, so we're going to have a look at the population. So if we were to take a snapshot, what are the main takeaways that we can see here? So globally, we have a majority of men coming from Africa, and men that have been in France for a while. So 50% have stayed in France for more than 5 years, has been staying in France for more than 5 years. 4 years, sorry. So health problems, something that you all expected. And the prevalence is higher than the one that we have for the general population, something that we could expect, of course, because we're talking about people that are having a difficult life. It's difficult for them. So, of course, the health is being impacted. So, second table. So now you have the results for this first question. So why do people do not benefit from the SMA? So here you have a significant data. It means that there is a strong correlation. And so it means that it is associated with the lack of access to SMA. So the most significant data is the duration of residence. So it means that the longer the people have been staying in France, the higher the probability for them to get access to SMA is. So it means that it's not the sickest people that get access to SMA. It was the first line in the previous table. We also have a 50% rate of people that do not seek SMA.
La CMUC et la CS qui sont maintenant devenues la C2S, mais c'est beaucoup plus que ces deux dispositifs-là.
So health is not the main factor. So the sickest people do not seek SMA the most. It's rather the people that have stayed in France for longer.
C'est intéressant au moins avec ce qui vient d'être dit, c'est-à-dire que là il y a une articulation.
To me, there is a strong link.
Entre le CADI et le CANTI, c'est-à-dire que nous ce qu'on voit, c'est que plus les personnes sont.
It means that the longer they've stayed in France, the higher the probability is for them to get SMA, but we can't really explain why. So there are a lot of hypotheses. Is it because you need, to be in France to understand how it works? Is it because people know better the administrative system, the medical system, and so you better understand how things work, basically? We don't really know. This is what Agnes was saying earlier. When it comes to the factors, the drivers linked to the duration of residence. So we need to understand what's the link between the two. And so to answer the second question, I'm sorry, we can't see anything here. It's too small.
La deuxième question, c'est de savoir est-ce que les personnes
But the question was, do people that have SMA go to different centers than the ones that do not have SMA?
Donc là, l'idée,
So here,
c'est que si
if you have SMA, so if you've been covered for a long time, you know the system better, and so you could think that you would go to medical offices and not to centers made for vulnerable people. This is the assumption that we made, and this is what we can observe. So it means that they go to medical centers rather than to the centers for vulnerable people.
Donc, juste pour rappeler rapidement, si on voulait avoir une idée,
And so, very briefly, to tell you more about our work, so we have a look at the factors, but we want to understand what causes what. And the non-use of SMA is linked to the duration of residence, and even for people that have been in France for a very long time, we have a big majority of people that do not benefit from SMA. So we still have people that are not covered by the SMA, even though they've been staying in France for a while now. And for people that are benefiting from SMA, we've seen that they go to medical offices rather than the emergency rooms or the dedicated centers. If you have questions on the methodology, don't hesitate to ask. Thank you so much, and I'm going to give the floor to Valérie.
Merci Antoine pour cette présentation.
Thank you so much for your presentation. Thank you so much as well for telling us more about your scientific approach. It's really at the heart of what we want to do today. I wanted to share a comment with you. So yes, the rates of non-use of SMA is really high. So we've heard a lot about SMA those last few months. We've talked a lot about the misconceptions around fraud or the abuse, but we can see that the majority of people do not get access to SMA. We've also seen that the level of health is not the first factor. And we know that health tourism also is something that we talk a lot in the xenophobic sphere. And so for the last intervention, we are going to leave France and we're going to focus on the works of Valérie Ried, Research Director on the departmentalization of mutual health insurance schemes in Senegal. So now we're going to talk about universal health coverage rather. And your works show how interesting that question is. Thank you so much. Hi, everyone. Thank you for inviting me, because the 4th of April is also the Independence Day of Senegal, and I'm sure you had planned all of this. So I'm going to talk about universal health coverage and health insurance policies, but I think that a lot of people will wonder why I'm going to talk about health insurance policies, because it's been shown that they aren't useless. And we know that in the villages, it's not a positive instrument, it's not a tool to be used for universal health coverage. All studies have shown that. The WHO also made the same observation. So why am I going to talk about this? Because there is a very original experiment in Africa, something happening in Africa that is extremely interesting. And so I'm going to tell you more about what's happening in Senegal. For a very long time, we had NGOs, not MDM, of course, that had worked in French-speaking parts of Africa to push for the use of health insurance policies, but it's a big failure because it doesn't work. It's not new. And I'm going to go back in time. Because when we have a look at the archives, we can see that even during the colonial period, people had tried to push for the use of a health insurance policy. So here you have, for example, the colonial mutual system based in Bordeaux, a city that is very open to Africa, to put things simpler. And so it was mainly in North Africa, Algeria, Morocco, Tunisia. But we hadn't worked a lot on that in Western Africa. We don't have a lot of things on those issues there. So in darker archives, in 1923, I found a list of different mutual policies, 7 total, and we had fewer than 700 people that had this type of mutual insurance, and for colons mainly. I also found those pilot projects that we've tried to push for, and the archives. I also found some discussions in between the general governor of the AOF that wanted to focus on implementing the principles of mutual insurance, and the lieutenant governor of the Ivory Coast. So they also wanted to push for this. But what's interesting here in the letter of the lieutenant governor of the Ivory Coast, so you have all of the misconceptions of that specific period. I'm not going to enter the details here, but we also had the idea of regionalizing things and that people had to pay for this. So there were different taxes for health as well. This was quite hallucinated, to be honest. But people also believed that people had, to pay for taxes locally, for taxes to be redistributed locally as well. And on the last slide, we have the thesis from Bart Creel from the 1990s for the Burunda health insurance. And so at the time, he suggested that we had to stop those those regional health insurances in order to switch to district-based health insurance policies. But the problem is that nobody has tested this, at least as far as I know, and Senegal has been testing this for a while, and so I wanted to share that story with you. So in 2013, the Senegalese government decided to implement a national program for district-based health insurance in the villages. And so the flagship program that was supported by USAID, for ideological reasons, of course, has decided to create one mutual insurance scheme per city, per village. So it was a big fragmentation. We had more than 600 mutual insurance policies in the village. And so anyone could adhere to the system, to the scheme. And of course, we had tens of studies carried out by economists as well, that are also carrying out studies to understand what are the drivers that increase the use of mutual insurances. So there were a lot of studies on their capacity to pay and on rural areas as well. So the Senegalese state, as well as other countries, has decided to fund 50% of the fees. So it was 7,000 francs. And so each household, each person will be able to adhere to that scheme for up to 3,500 francs. And you also have the poorest people that can join a specific system, and they will be able to adhere to a mutual insurance system for free. So the state will pay for the full fees. So that's the national program that was launched in 2013 in Senegal. So 10 years later, it's a failure because the studies have shown that the adhesion rate is around 5% only. We have a penetration rate of around 2.5%, below that even. So it means that less than 2.5% of the population have adhered to those mutual insurance policies. Of course, it's useful for the people that have paid for this because they can reduce their expenditures, they have an increased access to care, but for the poorest, it didn't have any impact. So we're talking about micro impacts because it represents less than 3% of the population. So in conclusion, it doesn't work. And in parallel, in 2014, the Belgian Technical Corporation, what we call CBT at the time, decided to support not this system, but systems at the department level. So decided to go to another scale. So here we're talking about 100,000 people. So we're talking about professionalizing, for example, mutual insurance managers. So we'd have, for example, a specific office that would manage everything at the departmental level with a very long process. And we would also create an allowance for the different structures of the department. So the goal not to pay for a medical act, but to pay for a package. For example, if you go to a nurse, it's 2,000 francs. If you go to the doctor, it's 10,000 francs if you have medication also added. And we also had a high portability of the system. It was quite revolutionary. That was the idea that was defended by Mr. Kritz, and so 2 departments in total. So this process has been capitalized upon in 2018-2019. So we had a big forum attended by more than 300 people in Dakar. Can you please move the mic closer to your mouth? Thank you.
Processus de capitalisation qui va...
So a full capitalization process to share some research results. The goal was not to share, tables that were very complicated, but rather political notes for people to better understand what was going on. So we had a very interesting ideological conflict, and we've tried to analyze it with one of my colleagues. So we had the cooperation from the Belgian authorities and the American authorities, and so we had different instruments used that led to a failure. And so now Senegal has decided to have those departmental systems, so another scale, but it's true that we lost 10 years in total. So those 2 systems are still existing today. So, sometimes we have smaller projects in regions when you have budget, and then when you don't have budget anymore, when you leave, and the projects sometimes stop. In a lot of NGOs, not MDM, of course, in the other NGOs. But what's interesting here is that the system that was pushed for by Enabel was stopped, but is still existing today, and is working very well today, even in 2024. It's quite interesting. So we've carried out a lot of different studies on the durability of that system. Why is it that durable? Why does it continue to exist despite the departure of the organization? Because, all of the colleagues on the field were highly dedicated, devoted to the cause, and so it was meaningful as well for those people. So it had a huge impact on the health system, because those 2 mutual insurance policies have bought the equivalent of 2 million euros in terms of services, so it means that they had a very strong power to act. We're going to talk about this in the next roundtable, so it means that they had a huge power of negotiation with the healthcare professionals. I'm not going to enter the details, but you can find the publication if need be. So, are they efficient? So on the left side, you have the penetration rates and the number of people that have adhered to those departmental insurance policies. So more than 80% in total have access to this kind of system. Earlier, I was talking about less than 3%, so it's quite of a success in Western Africa, a big success. And we can see that the operating costs are below 20%. So they are in between 15 and 19%. And in France, we are around 90%.
Des choses un peu ésotériques comme
And in France, the operating cost of the health insurance system in France is around 4%. So we have reasonable figures here. I'm not going to enter the details, but I'm going to talk about the heart of the solution. The heart of the solution is trust, satisfaction. In that specific context, we don't have a lot of knowledge on the efficiency of that type of system, but because, the rate has increased, because people are paying for those systems every year shows that people are satisfied in the end and that they trust the systems locally. So we can see that people really trust the processes.
So the idea of the government now is to upscale that project. So we've had a national assessment that was done in 2021 with about 12 reports that were elaborated, quite dense actually, but very interesting. And so the state realized that the solution of this mutual insurance, community-based, was no longer working, and that the district-based community insurance, district-based health insurance, was working pretty well. And so they wanted to deploy that on the national level. So here you can see all of the different districts. So the one that are colored are the districts in which all of the community-based and local health insurance were dismantled, were dissolved, because, as you can imagine, all presidents of the local mutual insurances no longer have their nice president's status anymore. So of course they're quite reluctant to see all of these mutual insurances being dismantled. But the state is really pushing for it and really trying to upscale this system in the entire country. So we don't have quantitative data, or at least we don't have quantitative data that is solid enough to assess the situation, because unfortunately when it comes to public policies, quite often we don't usually do serious research before implementing something. In France, for example, the minimum allowance, and Martin Hirsch, that you all know, I think, had decided to change everything, though the research was not even done yet. And I guess this is the same as well for the cervical cancer vaccine. We had everything deployed at a national level without even knowing whether the results were good. And so here in Senegal, this is pretty much the same thing. We're just upscaling the entire project, even though we don't have all of the data, that we don't have quantitative data, as I said. We only have the data that I've shown you today, which I don't think is enough. And so the idea is to try and see whether this new district-based mutual insurance is going to be a good thing at the country level. And finally, the last slide that I wanted to show you today, this is, of course, related to what my colleagues were saying, but this is all about also giving access to care to the poorest population. These people usually get money every trimester, usually around 25,000 and 30,000 francs, depending on the presidents. But so they get that cash transfer, and they also get free access to the mutual health insurance. So they're basically members right away. The major problem that we have here, one of the main problems that we have here, just like for the SMA, most of these people do not know that they can benefit from this, that they can have access to this mutual health insurance for free. And of course, this is something that costs about 19 billion euros to the state. But people don't even know that they have access to this. So we just started a research project that is funded by the Innovation Fund for Development. And so the idea here is to try and launch to kick off a navigation project. So what it means is that we have people in different villages that are supporting people that have the right to this allowance, to actually do everything they need to do for them to have access to this system. And then I just wanted to finish with one of the archives that I ran into completely randomly, but this is a text from Charles Dornier from 1907, and he was trying to prove how the fables from La Fontaine could actually be useful for the authorities, and trying to demonstrate the use of such system. And I thought it was quite interesting to show you that La Fontaine could actually be a great promoter of mutual health insurances. Thank you so much for your attention. Thank you, Valerie. And thank you for this very poetic conclusion as well. And thank you as well for giving us perspectives outside of France and outside of Europe. A lot of elements were really interesting. I think it's going to fit the debate as well. You've got the genesis of mutual health insurance in the colonial context. We talked about district-based health insurance. We talked about the scale when it comes to risk. You also talked about political reluctance and resistance to the implementation of that new system. And you also talked about the assessment of public policies as well and the impact it has on political decisions. So many different needs for this open discussion. I'm now opening the floor to questions. Whether you are in the room or in Zoom, you can definitely ask questions. So if you're on Zoom, you can just ask your question directly in the chat. So maybe I can just open the discussion by asking the first question to our guest speakers. So this is a current news question, maybe more for Agnès and Antoine. So the housing system, the SMA, system has been contested. We've had a lot of negotiations that were done outside of the parliament because Elisabeth Borne has committed towards the president of the Senate to do a reform a certain way. This is a commitment that was taken over by Gabriel Attal, her successor, and we wanted to do a regulatory reform, so by decree, and this is something that would be done before the summer. So in terms of the restrictions that are being under study at the moment, we've identified 4 different restrictions risks. So we have the aggregation of resources. So, as we were saying, we're not now taking, at the moment, we're not taking into consideration the income of their partners. So, for example, if you are with someone that is French and lives in France, for example, now they also want to limit the ID supporting document. There's also one restriction regarding the filing of an application. So for the first request, you would have to do it directly at the counter. And also there would be a restriction of the different health services you could have access to. For example, the CPAM would have to give their authorization upon care. So we're talking about individual care and public health. What would happen? What would be the consequences if this reform were to be adopted and were to be enforced? And yes. Well, when you're talking about, aggregating incomes, if we are not taking the partner's income, it's just because this is social rights. This based on the law. We're not supposed to be taking into consideration the partner's income. When it comes to SMA, you either get it or you don't get it. If we take into consideration the resources, the income of a partner, it means that the partner in question, who's undocumented, that partner will not benefit from the SMA. For a couple, if you want to have access to the SMA, the threshold is about 1,200 euros, which is under the minimum wage, which is below the minimum wage. So if you are an undocumented person and you are with a partner that has a minimum wage, in a relationship with someone that has minimum wage, the partner will not have access to SMA. There won't be any possibility for the partner to actually get access to that healthcare insurance, to have access to that SMA. Second point regarding supporting documents, especially IDs. Here, quite spontaneously, I would say that the risk would be that people would have to provide their real ID card, which means that they wouldn't be able, for example, to give their birth certificate that is accepted at the moment. I'm thinking of an asylum seeker that has been declined. because you have to send some supporting documents that are never sent back to you. And usually, asylum seekers are usually being declined 80% of the time, and they never send them back their ID card. So you can imagine they're always in an undocumented, in an irregular situation, sorry. We've also been able to talk about Justine's case. She's explaining how complicated it is, that she called 3646 many times. The hotline is just giving you a phone appointment for you to get a physical appointment. It's extremely complicated to get that appointment. It takes you forever to actually get there. And some people are sometimes faced with a real conundrum when it comes to how to get there and how long it's going to take. Should I take a day off and so on? So I think there's the risk of just adding obstacles on these people's path. And I think that fewer people are going to benefit from the SMA in the end. Yes, thank you, Mathias, for that question. I'll add up to what Agnès just said and try and answer your question. So let's take the example of Spain. Spain used to have an SMA as well. I mean, it had a different name, but it was pretty much the same system that we currently have in France. And this system has been cancelled in 2012, and they finally reintroduced it last year because they figured that it actually was useful. And so the argument here is just that the SMA is a fund as well that ensures solvency for hospitals. So I think having this type of system is just a system that exists and that should be maintained. And I think it's a good idea. And I have to say that Spain actually went back in time. They had to reintroduce the entire system that they had cancelled. And when they cancelled the SMA, the number of undocumented people in Spain was actually maintained. It's not as if people left the country suddenly because they no longer had access to SMA. If we no longer provide healthcare to foreigners, they will keep on coming anyways. So I don't think this is an argument, actually. This shouldn't be used as an argument because people do not come for free healthcare. Thank you. Thank you so much. And it really shows that despite scientific knowledge, the decisions that are made at the political level are not always rational. Any questions in the room or in the chat for our speakers? We might have time for several questions. Feel free, don't be shy. I can see 2 questions right on top of the auditorium. So I'll try and have a look at the different comments in the chat. I see a comment for Valerie. I read a report on social security in Senegal that showed that despite the increasing numbers of beneficiaries, there was no money, and in practice, people were not really reimbursed for the care they have access to. Maybe Valerie can answer that. And a second question, Valerie, could you please explain again the role of health agents when it comes to supporting patients for them to become members of the mutual health insurance? Maybe questions in the room? Yes, hi. This is a question for Valerie. Could you please precise what's the service package? What type of care are being reimbursed, what type of treatment are being reimbursed in this district-based health insurance system? Yes, hi. So you talked about the equivalent of the SMA in Spain, and I was wondering, how long has it been cancelled? What about the duration of that? All right, maybe Valerie, you can start answering the questions that you got. Thank you so much for your questions. Are they running out of money? Well, I'm not aware of that. This district-based health insurance do reimburse. Of course, usually the duration before you actually get reimbursed can be a bit long sometimes. It's true that when it comes to public health, just like in any other country in the region, sometimes it takes forever to get reimbursed. When it comes to supporting people in the villages in which we are experimenting that system, we have people that benefit from that. I mean, they have the right to have access to that, but they don't know, they're not aware of it. And so when they actually have access to it, they don't really benefit from it. So the idea is to have people, to have community agents, health agents, that would be in the villages to support these people. First of all, in the national project, they would have to identify people that could be eligible, that could benefit from that, and promote that system and help these people actually get access to what they can get. When it comes to the care package, I mean, there is portability at the district at the district level and want to go up to the region level, but with the district-based health insurance, you can now just be treated, you can be cared for anywhere. It used to be very complicated with the community-based approach, but now all of the members, they do have a card, and on the card you have all of the care package. They just have to get to the medical center with that card, and they can have access to care. So they have primary care, conventional primary care that they can have access to in the different clinics and medical offices, but they also have access to care at the district hospital. And so here they have the entire care package as well, so they're being reimbursed depending on the care that they get, actually, depending on the treatment that they're put on as well. And of course, we do have a lot of challenges, just as we have in France when it comes to access, to have access and to the shortages of different drugs, different medication. And so for now, they are being reimbursed. They have to reimburse medications and drugs that are bought in private pharmacies or private clinics, so that people actually can get access to the medication that they need. And when they go to these private pharmacy, if they are private pharmacies, they get reimbursed up to 50%. So as in every other country in the world, this district-based mutual health insurance is challenged because of chronic diseases that are, increasing in this region of Africa as well. And we don't have much treatments, and we don't have much specialists about this chronic disease as well. Thank you, Valerie. Maybe more information regarding the Spanish SMA? Yes, so to answer your question, this is a great question, actually. It's been cancelled for about a decade, I would say, but you have to keep in mind that the two studies that I've mentioned during my presentation, those studies were conducted before this decade of dismantlement. So I think that it's 4 years after they decided to cancel the SMA that these studies were conducted. But if you want, I can definitely give you the reference and tell you a bit more about the bibliography you want to have access to this research. Two more questions, in the chat. One question for Agnès. Does MDM work with the Immigration and Integration Office of France, so the Ministry of the Interior Agency in charge of assessing healthcare matters when it comes to migrants and asylum seekers? I'll let Agnès answer, and I can see two questions in the room. I wanted to know whether you think that the attack that we're faced with is only on the SMA, or it's also on the healthcare access points. What about these money to be given directly to hospital directors? I mean, I know that for the access points, it's probably going to be more restricted. And also when it comes to criteria, we can see that people are no longer eligible to the SMA because they are employed, they earn more than 900 euros per month. And the other question I had is that you talked about being, you would be considered in a regular situation after 3 years and with at least 12 pay slips. But I was wondering, are they considering increasing that quota? Thank you for that question. There's another question in the room. Yes, thank you so much for this round table. Maybe one lead, when you listen to Agnès reading through Justine's testimony at the Red Cross Foundation, I realized that there are many research actually that describe this phenomena. And I think that NGOs, humanitarian organizations, they work more and more with researchers nowadays. And I think that if if NGOs were able to talk about the logistics, about fundraising or collecting money. I don't think that we collaborate enough when it comes to research, because I think that we have other elements of that puzzle, you know, when it comes to not having access to household, to housing, sorry, or for example, gender-based violences. So we launched a magazine with other organizations and researchers, but I think that there are many more things that we could do all together so that we could help research actually keep on moving forward. And then I have a question for Antoine regarding the qualitative research that you were talking about. So you work, I mean, here you're doing a presentation for a scientific day with MDM. So when it comes to fighting for social justice and access to rights, I was wondering, what do you think the role of economist is nowadays? Thank you so much for this link with the scientific day. I think there are a lot of possibilities for collaboration. And I think there's the last question at the top of the room, and that's the last question that I will be taking so that we don't lag too much behind. Yes, so I do have a question. I'm just being curious. You talked about challenges that we faced when it comes to universal health coverage. And I was wondering, according to you, and taking into consideration your respective experiences, what were the best practices, international best practices, when it comes to social security and health coverage to reduce inequalities, and how could we actually enforce those in France?
On va essayer d'y répondre le mieux possible. Agnès, je te laisse peut-être...
Agnès, I'll let you answer the question regarding the OFI. Well, I have 15 seconds to answer that question, I think. So very briefly, it depends what you mean working with this organization. We might be faced with specific situation in the field. Of course, we work with asylum seekers, and we might also get social workers of the UFI to work with us so that we could try and get people to be hosted. You know, because maybe we have a couple sleeping in the street with a baby, and they've been in the street for 10 days, and they need to be sheltered. And so it depends on what you mean by working with the OFI. So there is also interference from the Ministry of the Interior when it comes to health matters, because those are the doctors from the OFI that can determine. So the Immigration Integration French office, they are the one to determine whether or not they can have access to it, whether they can have their first health consult. So it all depends on the Ministry of the Interior. It doesn't depend on the Ministry of Health. So it's not always easy. That's the first point. I'm just trying to be brief, I'm sorry. But when it comes to the attacks on the SMA, is it more of an attack on the on-call healthcare services? Well, I think that in France, everything is good to try and make us believe that we'll stop people from coming in the country. So we'll just stop people at the Italian border by just putting loads of police officers that have been housed for over 4 years in a camping site near Menton. So they're just there. They're on the highway. There are 3 different border checkpoints. So we've got the army as well over there. So I think we can use any type of argument to try and make people believe that it's by making migrants' life harder that it's going to make them not come. That's going to deter them from coming in the country. So I don't believe in that. You know, I gave you figures earlier on, and I'm sorry, Sophie, because I've been speaking too much, but I'm trying to answer all of your questions. When it comes to the collaboration in between NGOs and research, well, I would say, you know, I'm a coordinator of the different actions that we have in Nice. So we have the director of the French sector for health and advocacy. We also have the president of MDM. So I guess they would be better equipped to answer that question. Thank you for your question.
Merci pour la question.
That's a big question, actually. A very broad question. I don't know whether I consider myself more of an economist or more of a researcher. And I'm not sure whether or not I'm responsible for everything that other economists are saying. My job is to produce information with a methodology based on what economists do, so based on data and metrics. So the methodology is transparent, the data are accessible. I mean, we're trying to do this in a scientific way, right? To have a scientific methodology, to do things properly. And then we can decide whether it's credible or not. To try and quote other economists, for example, when we talk about the non-use of social rights, this is not being debated in between economists. We know that this is a reality. I mean, this is a fact. There is no debate on that. So, you know, this economist lens, I'm not sure this is the lens that I would use to critique here. I think it's more about the ideology at this point. It's not really based on a scientific results here. I mean, you can take the work of Florent Juzeau, who's an economist. That person works a lot on the use of rights. And there's no debate. I mean, of course we can debate, but what I mean is that the results are clear. But we can keep on discussing about this later on today. I'm really sorry. I think we're gonna have to close down this round table. It raises a lot of questions, political questions as well. You can definitely discuss this further during the break. Thank you so much for all of our guest speakers, for the quality of the presentation. We are lagging behind, so I think we're going to shorten the break. Let's do a 10-minute break. And let's get back in the room for the next round table, 11:40. So if you are online, please join us back in 10 minutes. And for those attending here on site, there is a coffee break planned for you in the room up there.